Pediatric gastrointestinal disorder, kabalo na kaani, cleft lip palate, church beyond submission, umbilical hernia, celiac disease. Societies, tracheoesophageal fistula and esophageal atresia. One or more clefts in the upper lip, from a small notch to a complete separation, cleft lip. Ranges from a soft palate alone to a defect including a hard palate and portions of the maxilla. Cleft lip is sa maxilla, sa maxillary and medial nasal processes failure to fuse. Cleft palate is palatal processes fails to close. So causes is environmental, hereditary, and smoking. Cleft lip is 1 to 1,000 births, more common in males. Palate is more common in females, 1 to 250. Incidence in female is double than in males. Notched upper lip border nasal distortion, deviated nasal septum. Notched at upper lip border nasal distortion. So, assessment findings for cleft lip, deviated nasal septum. Visible palpable gap in uvula, soft palate, hard palate, and or incisive foramen with exposed nasal cavities with nasal distortion. Visible, palpable gap in uvula, soft palate, hard palate, and incisive foramen, cleft palate. So, diagnosis for cleft palate and cleft lip. So, ineffective airway clearance, risk for aspiration. Yes, altered nutrition less than body requirements. Ineffective airway clearance, altered nutrition. Cleft lip, surgical management, chyloplasty, typically done to help infants experience the pleasure of swallowing, typically done at 1 to 2 months. Surgical management for cleft palate is done at 6 to 8 months to develop speech palatoplasty. 6 to 18 months. Normal speech patterns. Preoperative nursing care for cleft lip and palate. Feed infant slowly in upright position. Enlarge nipple. Burp frequently. Enlarged nipple. Stimulate sucking by rubbing into the nipple sa lower lip. Saan ang S? Swallow and rest after swallowing. Postoperative nursing care for cleft lip and cleft palate. Use elbow restraint, not too tight. Remove at least every 2 hours. One restraint at a time. Suture line is held by a Logan bar. Avoid blank every after. Avoid crying. Clean the suture lines after feeding. Is obstruction of the esophagus. Often a fistula occurs between the closed esophagus and trachea. Obstruction of the esophagus is this is esophageal atresia, while tracheoesophageal fistula is occurs between the closed esophagus and trachea. Caused by unknown, results from during feeding the milk can blank or the blank can allow milk to blank. During cause is unknown, result from failed separation of the esophagus and trachea by the septum. Failed separation of the esophagus and trachea by septum. So, nag-fail og separate sa ang esophagus ug ang trachea. During feeding, the milk can go to the trachea and can fill the blind esophagus and overflow into the trachea and fistula. During feeding, the milk can fill the blind esophagus and overflow into the trachea, or the fistula can allow milk to enter the trachea. Yeah. So mag-aspiration siya. Excessive drooling and aspiration. 3 C's. Coughing, cyanosis, and choking. Blank after feeding. Ano siya? Aspiration. What cannot pass? Apnea. Salivation and drooling. Respiratory distress after feeding. Abdominal distension because there's air. Catheter cannot pass sa tracheoesophageal sphincter. Nursing diagnosis for TEF. Of course, there is an effective breathing. Siguro kaya na ay altered nutrition or katong imbalanced nutrition. Risk for imbalanced nutrition, risk for infection. Ano mag-infection siya? So, blank, start. So, nursing for TEF, blank, start, or blank. Elevate with head of bed levated at 30 degrees or to prevent gastric juice from entering the lungs. Blank if necessary. NPO, so NPO na to siya, start IV fluids or TPN. Supine, na din na to siya, dito na siya elevate. Supine with head 30 degrees or to prevent gastric right or at or right side, left side daw ni if necessary. Intubate if necessary. So, NPO, start IV or NGT, IV fluids for TPN. So, stage operation of TEF and esophageal to empty the stomach with secretion we have. And prevent gastric reflux into the lungs. We are going to gastronomy. Gastrostomy, ligate mo na siya GLA. So, iligate ang TEF, anastomosis of esophageal segment. So, GLA. We are going to gastrostomy, ligation, and anastomosis. Is connected to gravity, drainage until feeding is tolerated. NGT, start with blank. Gastrostomy tube, sterile water. Start with sterile water, then frequent small feedings of formula. Gastrostomy is connected to gravity and drainage until feeding is tolerated. After feeding, blank. Do not blank. After feeding, elevate the end of the tube and clamp. After feeding, elevate the end of the tube and clamp. Transfer of gastric contents into the esophagus. Transfer of gastric contents into the esophagus. Transfer of gastric contents into the esophagus. GERD. So, ang mga gastric contents, nanda siya sa stomach, ning balik siya sa taas. Etiology, pathophysiology. So, there is weekend na LES. So, gastric contents, flushback, regurgitate of gastric contents into the esophagus, which causes aspiration and respiratory disorders. Assessment findings of gastroesophageal reflux. So how do we assess findings of gastroesophageal reflux? There will be katong crying, regurgitation, vomiting, excessive crying, heartburn, abdominal pain, recurrent pneumonia. So, rehar, heartburn, abdominal pain, rehar. Nursing diagnosis for gastroesophageal reflux, katunayin koan, malnutrition, imbalanced nutrition, risk for imbalanced nutrition. Feed infant with blank, with thickened cereal, 1 ounce per blank in blank. Keep infant blank for blank after feeding. Thickened formula, thickened with rice cereal, 1 tablespoon of cereal per 1 ounce of formula or breast milk. Upright position, upright for 1 hour. So, with formula thickened with rice cereal, feed infant with formula thickened with rice cereal, 1 tablespoon of cereal per 1 ounce of formula or breast milk. Keep infant upright for 1 hour after feeding. And 1 tablespoon of cereal per 1 ounce of formula. You can put it rice, yeah, 1 tablespoon cereal. Okay, management for GERD, reduce the possibility of stomach acid irritating the esophagus. Medical, so we have ranitidine or omeprazole. H2 receptor antagonist. Protective lining H2 receptor. PPI is for the lessen of the acidity. Surgical management for GERD is imuhang unsa ni mo ang lower esophageal sphincter. Imuhang i-tighten or suture. Inserting NGT post-op and attached to intermittent low suction. Insert NGT post-op and attached to suction. Narrowing of the pyloric stenosis. Exact cause is hereditary. Unknown. Muscles surrounding the pylorus progressively hypertrophy, leading to gastric emptying, impaired gastric emptying. So dili siya libang. So impaired gastric emptying, dili siya maka-excrete. Assessment findings for pyloric stenosis. Pyloric stenosis, currant-like jelly stools, progressive projectile non-bilous na vomiting, movable, palpable, peristaltic waves, left upper, right lower, irritability, hunger, crying, and also na po siya signs of dehydration. Irritability, hunger, crying, signs of dehydration, bulging fontanelles, sunken fontanelles, poor skin turgor, dry mucous membrane, decreased urine output, constipation, jaundice, metabolic alkalosis. So, nursing diagnosis for pyloric stenosis. Risk for impaired nutrition, risk for airway clearance, ineffective airway delay, risk for aspiration lagi, ineffective breathing pattern, altered nutrition less than body requires, risk for fluid volume deficit. So risk for aspiration and risk for fluid volume deficit. Creating an incision along the anterior pylorus to split the muscle, pyloromyotomy. Nursing management for pyloric stenosis. Nursing management for pyloric stenosis. MIO. Kasi pasabot. Nursing management for pyloric stenosis is monitor input and output and small frequent feedings of clear liquids within 4 to 6 hours post-operation. Protrusion of the abdominal contents through the abdominal wall at the junction of the umbilical hernia. Omphalocele. Abdominal contents through the abdominal wall at the junction of the umbilical cord and abdomen. Congenital defect in the abdominal wall fails to close to the right of the normal umbilical cord. Intestinal prolapse through the defect, no membrane covering exposed. Gastroschitis. Assessment findings: obvious protrusion of the abdominal contents at the time of delivery. Diagnosed by ultrasound. Obvious protrusion, gastroschitis ni. Nursing diagnosis for gastroschitis, risk for infection, and risk for imbalanced nutrition less than body requirements. Herniated, risk for imbalanced nutrition. Herniated organs are usually the blank, may include the blank. Okay, so wait lang babe.